My name is Peter Schmid. I'm a medical oncologist and work at Barts Cancer Institute in London. I lead the immune therapy program there, looking after patients with lung and breast cancer. It's my pleasure to talk today to you about the efficacy and safety of immune checkpoint inhibitors in non-small cell lung cancer, with a key focus on PD-L1 and PD-1. As we know, for immune therapy, there are a few things that need to come together. On the one hand, we need to have neoantigens which are linked with mutations. On the other hand, we have to have tumor-infiltrating lymphocytes that can be activated and then tackle the cancer. If you look at lung cancer, as you can see on this slide, lung cancer, squamous cell lung cancer as well as non-squamous cell lung cancers are characterized by a higher rate of somatic mutations compared to many other tumors. So from that point of view, non-small cell lung cancer has always been a good candidate for cancer immune therapy. If we look a bit more into the biology of non-small cell lung cancer, we can see there are very distinct groups depending on the immune infiltrate. There's a group with high PD-L1 expression on the tumor cells, and there's a separate group with high PD-L1 expression on immune cells. These groups have very different biology in the way the immune system is activated and behave very differently clinically. On the other hand, when it comes to cancer immune therapy and treatment with immune checkpoint inhibitor, and in this case with atezolizumab, we can see that both groups, tumors that have a high tumor cell expression of PD-L1, as well as tumors that have immune cell infiltration with PD-L1 positive cells, respond equally well. So the subtype of immune expression seems to have less relevance for the response to immune therapy, but it's important to recognize that PD-L1 expression is not just on tumor cells, but also in immune cells in non-small cell lung cancer. If you look at the very first data we received with immune checkpoint inhibitors in non-small cell lung cancer, we've learned very early that patients have substantial responses to single-agent therapy, whether it was with atezolizumab, pembrolizumab, or nivolumab. I would like to share one of the cases of one of the first trials we did with cancer immune therapy in non-small cell lung cancer. This is a case of a 66-year-old lady who's a former smoker with a history of 3 packs per day for 35 years. She was diagnosed in 2011 with metastatic lung cancer and metastatic involvement in lung, bone, soft tissues, and brain. Her molecular analysis showed that the tumor was wild type for EGFR and ALK. She had her solitary brain metastasis treated with stereotactic radiotherapy, then received as first-line treatment standard chemotherapy with pemetrexed and carboplatin, followed by consolidating radiotherapy. She progressed just at the end of 2012 and had second-line chemotherapy before she progressed again and was enrolled in a single-agent study with the immune checkpoint inhibitor atezolizumab. As you can see, at baseline, her disease was widely spread, as you can see on the PET-CT scan on the left side and the CT scan on the right side. Tumor was strongly positive for PD-L1, as you can see on the slides up here, with strong expression of tumor cells for PD-L1 in this lady. When we treated the patient, she had a very quick symptomatic improvement, and her scan after 3 cycles, as shown on the right side, shows a dramatic response of her tumor manifestations on PET-CT, and this was confirmed on her CT scan. So it's a classic example of a patient who responds very, very quickly, has a dramatic response to immune checkpoint inhibitor. And these early studies were the basis for a whole series of randomized phase 3 studies that explored the efficacy of different single-agent PD-1 or PD-L1 targeting treatments compared to docetaxel as second or third-line chemotherapy in patients with advanced non-small cell lung cancer. Patients in these trials had to have progressive disease after at least 1 line of prior platinum-based therapy, and patients with EGFR mutant tumors or ALK rearrangement had to have received targeted therapy. I'm presenting all these studies together. These are studies involving nivolumab in CheckMate 17, which is a study focusing on squamous cell cancers, nivolumab in CheckMate 57, another randomized phase 3 study focusing on non-squamous histology, the OAK study with atezolizumab that combined squamous and non-squamous tumors, and the Keynote 10 study, which had only patients with PD-L1 positive tumors and they were treated with pembrolizumab. If you look at the first endpoint for this trial, overall survival, you can see that in all these studies, overall survival was positive. There are differences in how early those curves separated, but essentially in all studies there was a hazard ratio between 0.59 and 0.73. All studies met the endpoint that single-agent immune checkpoint inhibitor therapy, whether it was targeting PD-1 or PD-L1, was significantly superior to second-line chemotherapy with docetaxel. There was a long discussion initially whether patients with squamous cell cancers would benefit differently and possibly better than patients with non-squamous histology. But again, as you can see here from the OAK study, there was no difference in the hazard ratio for patients with non-squamous cancers or patients with squamous cancers, hazard ratio for survival being 0.73 in both subgroups. Similar results were observed within the KEYNOTE-010 trial. So at this point in time, we could not see a clear difference between squamous cell cancers and non-squamous cell cancers, and most studies going forward are allowing patients with both histologies in the same trial. One interesting question is there a difference in benefit in terms of overall survival depending on the PD-L1 expression? As you can see, these trials had PD-L1 negative patients in there, patients with PD-L1 positive tumours, and the data here are shown by different cutoffs. PD-L1 positivity defined as 1% or higher, 5% or higher, 10% or higher, or a subgroup of patients with 50% or higher. I think what we can see from this slide is in all subsets, PD-L1 high, PD-L1 positive but not high, or PD-L1 negative, in all subsets, patients did derive a substantial benefit in terms of overall survival if they were treated with an immune checkpoint inhibitor in second or third line treatment as compared to docetaxel. We can discuss whether there may be a slightly higher numerical benefit for patients with higher PD-L1 expression, but the variation between trials is significant there, and I don't think we can make this statement very clearly at this point in time. What about progression-free survival? And progression-free survival is slightly different if you look at the different trials. As you can see, in some trials there's early separation, and if there's early separation of the curves, that led to a clear benefit in progression-free survival, as you can see in the CheckMate 17 trial for squamous cell cancers. In other studies, there was initial crossover, which means initially patients with chemotherapy had a slight benefit, but later on there was a crossover. And as we can see in all trials, there's a tail of the curve that if you wait long enough, patients with immune checkpoint inhibitors will have a benefit in terms of progression-free survival, but it depends on how early those curves separate, whether those results were positive comparing the overall curves between docetaxel and immune checkpoint inhibitor therapy. Now, what is interesting is looking at PD-L1 expression and PFS. And as you can see on the left of the slide, these are patients with PD-L1 negative tumours. And in these tumours, the data are obviously not consistent between the trials. But I think if we were taking an average of those three trials, there's no clear benefit in terms of progression-free survival for PD-L1 negative tumours. Whereas if you focus on PD-L1 positive tumours, and especially on tumours with higher expression of PD-L1, there seems to be also a benefit in progression-free survival. Some of this in progression-free survival compared to docetaxel is dependent on how well patients respond. And if you look at the response rate here of nivolumab versus docetaxel, we can see overall the response rate of immune checkpoint inhibitors is also higher compared to chemotherapy. And more importantly, the duration of response with 17 months compared to 5.6 months, again, is significantly better. But the important question here is how does response and PD-L1 expression, how are those two things connected? And if you look at the data from across those trials from KEYNOTE-10, CheckMate 17, CheckMate 57 and OAK, you can see there are differences. There are differences in response rate. In KEYNOTE-10, in the group with 50% or higher PD-L1 expression, the response rate of a single-agent immune checkpoint inhibitor therapy is very high, with 29% compared to 8% with docetaxel. Whereas if you look at all comers in OAK, which includes PD-L1 positive and negative patients, there's barely a difference between chemotherapy and atezolizumab in this study. And if you look on the right side of the slide, depending on the amount of PD-L1 expression, either on tumor cells or immune cells, with atezolizumab from the OAK study, the higher the PD-L1 expression is, the bigger the difference in response rate observed between chemotherapy and immune checkpoint inhibitor. In other words, if there's high PD-L1 expression, tumors tend to respond better to immune therapy, whereas if there's lower absent PD-L1 expression, then the response is still there, but the response is no longer significantly better compared to docetaxel. And taking this into consideration, this will explain the differences in PFS analysis between the different studies, because some of the studies like OAK, where there was little difference in response rate, is also a study that did not show a significant benefit in progression-free survival, whereas if you select other studies that have more patients with higher, for example, PD-L1 expression, are therefore more likely to respond significantly in terms of an objective response to immune checkpoint inhibitor therapy, the studies are more likely to show a difference in PFS. The interesting observation is when it comes to overall survival, response does not seem to be that relevant. In other words, patients can have an overall survival benefit even if there's no clear difference in response rate. But when we need to achieve an objective response, then patients who have higher expressing PD-L1 tumors are more likely to have a substantial response of immune checkpoint inhibitors. Now, with the substantial benefit of single-agent immune checkpoint inhibitors in second and third line therapy for non-small cell lung cancer, the key question is, how well do these agents work in first-line therapy? If we look at first-line therapy, it becomes also more relevant to differentiate the different subtypes of non-small cell lung cancer. And if you look at the expression of or the infiltration of tumor-infiltrating lymphocytes in non-small cell lung cancer, we see there's a group that's highly infiltrated with immune cells. It is what we call a hot or inflamed tumor type. These tumors are often characterized by high expression of PD-L1 checkpoints, by high infiltration of CD8 positive cells, by an activation of those cells as measured by an interferon gamma signature, by higher mutational load and by higher TILs. On the other hand, we have other tumors where there's still immune cells around, but these immune cells seem to be around the tumors and can't infiltrate into the tumor itself. And this is a group called excluded infiltrate. There's a third group of tumors that are relatively cold. They have low amount of T cells and often low MHC class 1 and are often differently in terms of their proliferation rate. As you can imagine, the immune therapy strategies for these tumors should probably be different. Tumors that are inflamed or hot tumors may be excellent candidates for single-agent immune checkpoint inhibitors, and we have data, and we'll share data with you in a minute, for patients that fit this category with non-small cell lung cancer diagnosis. On the other hand, patients with excluded infiltrate, we need to work on combinations to bring those tumor-infiltrating lymphocytes back into the tumor, and these combinations can, for example, be CTLA-4 or other partners, or combinations with vascular targeting agents, or, for example, MEK inhibitors. And possibly with this, we can increase the infiltrate and therefore then in a second step activate those immune cells and have an immune response. More challenging is how to treat patients with cold tumors, and we need to work on priming and activating those, the immune system there and leading to better infiltration, possibly also modulating the neoantigen expression, but this is not achievable in general with single-agent immune checkpoint inhibitor therapy, and again, these tumors should be considered for combination therapy. In terms of combination therapy, what is important is to understand the whole immunity cycle that happens, or the interaction of cancer and the immune system. And the immune system starts, the effect of the immune system starts with antigens being released of cancer, and of course, if you, for example, have more cell kill through radiotherapy or chemotherapy, then it can lead to increased antigen release. These antigens need to be taken up in antigen-presenting cells, be presented to the immune system. It leads to priming and activation of immune cells, which are then transported to the tumors, infiltrate the tumors, recognize the cancer cells, and can ultimately lead to destruction of the cancer cells. And there are various phases in this immunity cycle, and we can use different combination strategies depending on where we are in terms of the tumor biology. Cold or immune desert tumors will require the combination therapy to basically lead to increased priming and activation of the tumor cells. Whereas tumors with excluded infiltrates, where the immune cells are already there, they just can't get into the tumor, may require different combinations that enable the immune cells to better penetrate into the tumor. Inflamed cancers, and this for lung cancer may be the group of 50% or higher PD-L1 expression, these tumors may and seem to be responding very well to single-agent immune checkpoint inhibitor therapy, but again, there's still room for improvement, and we can still look at combinations to possibly improve the outcome of this subgroup as well. Now, if you look at patients in first-line metastatic and first-line advanced non-small cell lung cancer, there's one interesting study, KEYNOTE-24, that was presented at the ESMO meeting in 2016 in Copenhagen. This is a randomized trial comparing standard platinum-based chemotherapy with immune checkpoint inhibitor pembrolizumab in first-line treatment for patients with non-small cell lung cancer. But the trial only allowed patients with 50% or higher PD-L1 expression. And as you can see, there was a substantially higher response rate of 45% for pembrolizumab compared to chemotherapy with 28%, where even a handful of patients who had complete response to immune checkpoint inhibitor therapy. If you look at progression-free survival on the left side, again, early separation of the curves in favor of the immune checkpoint inhibitor, with 10.3 months on median compared to 6 months median progression-free survival with chemotherapy. And also in terms of overall survival, these early data show that there's a clear benefit in overall survival with a hazard ratio of 0.6. So if you select a group of patients that have inflamed tumors characterized by high PD-L1 expression, single-agent immune therapy can have a substantial response and has performed better than standard combination chemotherapy as first-line treatment for non-small cell lung cancer. Again, if you look at the other subgroups, because not every patient, this is only a third of the patients who have high PD-L1 expression, not everyone will be a candidate for single-agent immune checkpoint inhibitor therapy. And most of the combinations at the moment are focusing either on combination of CTLA-4 and PD-1, PD-L1 axis, or chemotherapy in terms of what has been going on in phase 3 studies. There's a whole range of other early phase trials that are exploring different combinations that tackle at different points in this immunity cycle, and we will learn more about these results in the next years to come. But as it stands, the randomized trials at the moment are with CTLA-4 combinations or chemotherapy combinations. Now, what is the rationale for combining chemotherapy with immune therapy? There are two main things we want to achieve. The first thing is, as we established earlier, there is some link between PD-L1 expression and response rate. And what we're trying to achieve with combinations is make patients who have PD-L1 positive tumors respond better, increase the response rate in those PD-L1 positive patients. But also the other hope is to have more patients with PD-L1 negative tumors respond better and ultimately increase the overall efficacy of immune therapy in patients by combining it with a second agent, in this case chemotherapy. Now, for many years we thought combinations of chemotherapy and immune therapy are counterintuitive because people were claiming there are negative immune effects of chemotherapy. But actually what we've learned is there's wide potential for synergistic activity between chemotherapy and immune therapy. For example, chemotherapy can reduce the T regulatory cell activity within tumors. Also, chemotherapy can help with cross-presentation of tumor antigens, especially if chemotherapy can lead to substantial cell kill. And chemotherapy can also, in a very dynamic way, change tumor cell expression and infiltration of CD8 cells and tumor cell expression of PD-L1. So there's evidence from many preclinical studies of synergistic activity between chemotherapy and PD-L1 treatment. What clinical data we have at the moment, there are a number of small cohort studies with nivolumab, pembrolizumab and atezolizumab, which all show impressive early phase activity in terms of response rates. Response rate, objective response rate are in the high 40s, 50s, in some studies up to 70% of combinations with platinum-based chemotherapy mainly and immune checkpoint inhibitors. And this led to a series of phase 3 studies which are ongoing, which investigate the benefit of adding immune checkpoint inhibitors to standard platinum-based chemotherapy in the first-line setting. One of these studies showed early results, and the KEYNOTE-21 trial was comparing patients with carboplatin pemetrexed chemotherapy with and without pembrolizumab. And then patients were continued with pembrolizumab or could receive pembrolizumab at disease progression. This is not a phase 3 trial, this is a small randomized phase 2 trial with a total of 123 patients. All patients were chemo naive and patients were not allowed to have EGFR mutations or ALK translocations. As you can see from the results, the response rates were substantial and were better for the combination of chemotherapy and pembrolizumab compared to chemotherapy alone. 55% with the combination achieved an objective response compared to 29% with chemotherapy alone, which compares well with what we know from other phase 3 trials. If you look at the expression of PD-L1 and response to the combination, there isn't a clear group that does substantially better, apart from the group of 50% or higher PD-L1 expression, but we seem to have similar response rate in these small numbers for patients with PD-L1 negative tumors or patients with low PD-L1 expression if immune therapy is combined with chemotherapy, whereas patients with absent PD-L1 expression seem to be having less of an effect of chemotherapy when given alone. If you look at progression-free survival in a small randomized phase 2 trial, again, there's a clear trend, there's clear improvement with the combination of chemotherapy and pembrolizumab for 13 months compared to 8.9 months with chemotherapy alone. However, the overall survival data at this point, as you can see on the left side of the slide, show no difference between chemotherapy alone and pembrolizumab plus chemotherapy. Now, if you look at the number of events, the study is not mature yet for overall survival, and we need to wait and see whether those results may change over time. But it's obviously a concern at this point in time whether the combinations of chemotherapy and immune therapy will lead to the same substantial benefits in terms of survival as we have noticed with single-agent immune therapy, and we need more time and results from other phase 3 trials that'll be coming out in the next few months to confirm this further. If you look at the different subtypes of non-small cell lung cancer and the different possible immune therapy strategies, we have a subgroup of patients of around 15 to 30% who have high PD-L1 expression. High expression defined as more than 50% PD-L1 expression. And these, according to the data I shared with you today, are excellent candidates for single-agent therapy with PD-L1 or PD-1 targeting agents. What about patients with ALK rearrangement or patients with EGFR mutations? Again, for these patients, we need to wait for combination data of immune therapy and targeted therapy, and at the moment we can't define the optimal standard for these patients. But for the large group of patients who are PD-L1 negative or have lower PD-L1 expression, although being PD-L1 positive, the question is, what is the best strategy for these patients? Should these patients be considered for single-agent immune therapy, for chemotherapy, for example, up front, or is there benefit of combinations of immune therapy, for example, with PD-1 and CTLA-4, or of combination of chemotherapy and immune therapy? Now, you know that there's a range of phase 3 studies ongoing, and there was a recent press release that a phase 3 study of durvalumab and tremelimumab did not meet its primary endpoint compared to standard chemotherapy in the first-line setting, but it was only reporting data on progression-free survival, and overall survival data are not yet available. So again, we can't definitively answer this question whether PD-L1 CTLA-4 combinations are inferior, equivalent, or superior to chemotherapy in the first-line setting. And we are eagerly awaiting results from phase 3 studies of chemotherapy, immune therapy combinations in first-line therapy, which should be awaited in the next few months. Where are we going with immune therapy in lung cancer? And this is really to finish the talk for today. We know for patients who have high have inflamed tumors with high expression of PD-1 or PD-L1, we can consider single-agent PD-1 and PD-L1 targeted agents. But the problem still remains what we're doing with cold tumors, and there are different strategies that are being pursued. One is to bring T cells into the tumors, and this is with combinations, as we discussed, of chemotherapy, of CTLA-4, of other immune-activating antibodies. And there's a whole range of targeted treatments that are currently being explored in combination with immune checkpoint inhibitors to bring T cells into the tumors and therefore make the tumors more inflamed. Other strategies are looking at generating T cells and again then bringing those T cells obviously to the tumor, and there will be a lot to be expected from, for example, CAR T strategies, which are just going into the clinic in solid tumors as well. If we look at safety and management of side effects, I would like to share again a case report And when we share our case reports of patients, we usually focus on side effects. Having said this, most patients with immune checkpoint inhibitors, at least single-agent immune checkpoint inhibitors, will experience very, very few side effects compared to chemotherapy. Now, this is a patient we treated, 60-year-old former smoker who received first-line therapy with gemcitabine and cisplatin, and then relapsed within a year with lung metastasis, as you can see on the CT scan. The patient was started on an immune checkpoint inhibitor, and 4 weeks after we started the patient, he came back and was fatigued, reported on mild shortness of breath, had some diarrhea, and had also experienced fever. So it's a mix of different symptoms. Investigations show there was an elevation of liver enzymes, the platelets were lower, there were no signs of infection, and their respiratory function was normal. When we assumed that most of these symptoms are immune-mediated, the treatment was paused, the patient was started on systemic steroids, and as you can see, very, very rapidly the platelets recovered, the liver enzymes went back down, and patients and all the changes on the CT scan, which suggested pneumonitis, resolved very quickly, and the patient could successfully continue his treatment with the immune checkpoint inhibitor. Now, if you look at toxicity of the immune checkpoint inhibitors, there is a balance between immune tolerance and unchecked immune response. What we are essentially achieving with immune therapy is we are shifting the symptoms from immune tolerance more to an immune response. And sometimes we do this too well, and patients will develop immune-related adverse events, which are essentially a form of autoimmune reactions. And it can, in theory, affect any organ, but what we most commonly see with PD-1 or PD-1 targeting agents is inflammation of the skin, of the gastrointestinal tract with diarrhea, sometimes elevations of liver function tests, sometimes pneumonitis, endocrine effects, most commonly with hypothyroid, and very rare cardiovascular effects. General events like fatigue, fever, chills, infusion reactions are relatively rare. One key message for all immune-related adverse events is if you look at this slide and see that the reactions are down to a shift to the left, what we achieve with immune therapy, we are trying to shift this back to the right, and this can be done with steroids. So if patients on immune therapy develop adverse events, it is important to start them as early as possible on corticosteroids, because those steroids can very efficiently and very quickly counteract the side effects patients have. It's unclear at what time these side effects can occur, and some side effects tend to occur a bit earlier, but ultimately they can occur at any point in time, whether it's rash, diarrhea, endocrine effects, or liver toxicity. So just looking at the time point when toxicity occurs doesn't necessarily tell us whether it is an immune-related adverse event or not. Most immune-related adverse events are reversible with steroids or with other immune suppressants, but hardly ever do need more substantial immune suppression. The key thing for us, and it's really an important message from my end, is early recognition is essential. Early initiation of treatment is also essential to reduce the risk of complications. And especially teams that have not much experience with immune therapy may need to consult with appropriate medical specialists initially until they are more used to some of these rarer side effects. Are there differences between different immune checkpoint inhibitors? There are no differences between PD-1 and PD-L1 targeting agents, but there are significant differences between CTLA-4 targeting agents and PD-1 or PD-1 targeting agents. CTLA-4 agents are more in the priming phase, in the central phase, whereas PD-L1 targeting agents are more effective in the effector phase, i.e. in the peripheral tissue. Consequently, the side effects are much more if it's a central intervention in the immune system compared to a peripheral intervention. We have more substantial side effects with CTLA-4 targeted agents compared to PD-1 or PD-1 targeting agents. With PD-L1 targeting agents, which is the mainstay of treatment at the moment for non-small cell lung cancer, side effects are very rare, are usually mild, and are well controlled. And again, this is just some rough guidance of how we treat immune-related adverse events. Patients who have grade 1 events are usually okay to continue on their treatment with the immune checkpoint inhibitor. Sometimes we try to treat them symptomatically, but most of these patients do not require systemic steroids. but from grade 2 events onwards, grade 2, grade 3 or grade 4 events, patients are commonly, and for grade 3 and 4 definitely should be considered for systemic steroids. For grade 2 events, apart from some selected, we can still continue the treatment, but when it comes to grade 3 or 4 events, usually the treatment should be withheld. There's a few selected adverse events like diarrhea, pneumonitis, liver or renal toxicity, where even at grade 2 events, we would always start with steroids and would also hold the treatment until we know how the toxicity is resolving. Steroids, again, need to be adjusted depending on how severe the symptoms are, but a good starting dose tends to be 1 to 2 milligram per kilogram body weight, but sometimes we need to escalate to 3 to 5 milligram of prednisolone equivalent. If there's significant toxicity, for example, liver or pneumonitis, then it is important to slowly taper or not to rapidly stop the corticosteroids. We would usually slowly taper over 4 weeks or longer. And sometimes, but only in rare cases, we need several courses if the symptoms don't go away or tend to get better. What I tried to give you today was an overview of the role of immune checkpoint inhibitor in non-small cell lung cancer. Immune checkpoint inhibitors have become standard of care as second and third line treatment for patients, as they have consistently shown a clear benefit in overall survival compared to standard chemotherapy. They can also be associated with high response rate, especially if patients have PD-L1 highly expressing tumors. In first-line treatment, at the moment, immune therapy should be considered as a standard option for patients with high expression of PD-L1, defined as 50% or higher, and their immune checkpoint inhibitors have been shown to give superior outcome compared to chemotherapy. In patients with lower PD-L1 expression or no PD-L1 expression, we have to wait for trials that are expected to come out in the next few months that either explore the combination of CTLA-4 or PD-L1 agents or combinations of chemotherapy and immune checkpoint inhibitors relative to chemotherapy, and they will define the role in first-line treatment. It is my pleasure now to pass on to Dr. Camillo Porter, who will talk about the efficacy and safety of immune checkpoint inhibitors in bladder cancer and other GU cancers. Thank you very much.